Healthcare is actually going to be my moderator. And I joked with him offset to say that I had absolutely no idea in all this discussion that I've been having with him that he was such a nerd. And so we're going to move to the very final panel discussion. And again, the topic is value-based healthcare, leveraging data and outcomes to build purpose, profit, and prudence into healthcare. And as I said before, my moderator will be Dr. Walcott here, and he's extremely modest, but he's just going to have to deal with my introduction of him. So here goes. He is a medical doctor and an entrepreneur with over 5 years experience as a founder, operator, and consultant to several businesses in the Caribbean. His academic profile includes Oxford, INSEAD, and Harvard. I told you he was a nerd. He is committed to attracting world-class healthcare resources into the Caribbean and has worked on several multi-million-dollar healthcare projects in the Caribbean. He's the founder of Novamed, a company driving the adoption of innovation and innovative healthcare solutions in emerging markets, and founding partner of the Visionaries Summit. Just some highlights: he is a Rhodes Scholar, co-chair of COVID steering committee of the World Economic Forum Global Shapers Community, Ph.D. in immunology, and I mean, he does it all. I asked him, how does he have the time? How does he find the time? Does he have a social life? He tried to convince me he does, but I truly am extremely privileged and pleased to welcome our very final moderator, Dr. David Walcott, who will be running the very last panel session. Over to you.
Thank you very much, Terry, and thanks for the very decorated introduction. I can assure you that the speaker who I'll introduce has a much more respectable and stellar bio than I do. And, you know, I think this conversation is really appropriate now that we are, you know, towards the end of day one. One of the main themes we've seen is collaboration. And it's important for us to realize that collaboration itself is a tool, but it has to be organized around something. The question is, what is that organization, collaboration aligned around? And we have different sort of perceptions as to what innovation looks like. It should be remembered that today's innovation really is yesteryear's previous innovation, in the sense that telemedicine, which has sort of caught up to speed with COVID-19, had actually been pioneered by a company known as Teladoc in 2002. And now we're climbing up the curve. The question is, what is the next innovation? And we have to sort of broaden our horizons and look beyond the sort of low-hanging fruits of innovation and seek to pursue these innovative business models that are outside the box. And again, there's no better speaker than Professor Robert Kaplan. Bob Kaplan is a senior fellow and a Marvin Bower professor at Harvard Business School. He joined HBS in 1984 after 6 years of deanship at Carnegie Mellon. And he has authored over 14 books. He has written over 200 academic papers. And he also is the inventor of several business tools, including activity-based costing and the balanced scorecard that have been used by organizations around the world. So Bob, welcome to the discussion. We're very glad to have you. And
Hello, David, and happy to be joining you at this panel and very important conference.
Thanks, Bob. Thanks for chiming in. Now, Bob, you are, you know, perhaps one of the most distinguished proponents of value-based healthcare. And value-based healthcare is increasingly seen as one of the more sort of interesting and innovative business models in healthcare. Can you set the stage and tell us a bit about what exactly value-based healthcare is?
Okay, so would you like me to now give this maybe 20-minute presentation, an overview on value-based healthcare, and then we can come back to discuss?
Sure. I'd love for you to share your slides and sort of introduce the audience into what value-based healthcare is and how it sort of functions in emerging markets.
Okay, so I'm counting on Chloe to be able to make my screen visible to everybody. And the reason I'm doing this rather than just having a conversation with David is that unfortunately value and value-based healthcare has become a buzzword in healthcare, and people interpret it to mean whatever they want it to mean. If I'm doing something different from what I did last year, then it must be value-based healthcare. And that's not a very good situation. I think it's important to know specifically what we mean by value-based healthcare. So there's really only, kind of one view of what that is. And that is really why I asked David to take the time to go through what it is, and I'll try to illustrate with particular examples for low and medium income countries, which I understand is the main constituency and participations in this wonderful conference that you have organized. So the definition of value-based healthcare is that we want to deliver care in ways that have better outcomes, and we measure the outcomes that matter to patients, not outcomes that matter to doctors or to policymakers. It has to be the outcomes that the patients experience, and do that at a lower total cost of care. So my strategy colleague, Michael Porter, writes it as this equation. It's not literally an equation because, as we'll see, the outcomes are multidimensional and measured in different units. When I asked him about this, he says, Bob, don't be too literal about this. We want them to understand that we want the numerator to go up and the denominator to go down. And that's the goal and that's the destination of what we are trying to do in this new mode of healthcare delivery. But there are two other components in this as well. Where do we measure value? And the value has to be measured at a patient's medical condition. We really can't measure value at a hospital or a physician practice or a clinic because there's too much stuff that goes on there. You're treating too many conditions. And value is created at the condition level. And it's not just for an intervention. It has to be for a treatment over a complete episode or cycle of care for that condition. And so those are the four principal components in the value-based healthcare definition. Improve outcomes that matter to patients, do it at lower cost to society, lower cost of mix of resources, measure it at the medical condition level across the cycle of care. And we'll illustrate that. That sounds very general, but it has a very specific meanings. And to do this, we advocate 4 principal steps. And the point is you can't just do one thing and say now we're aligned with value. We have to change a lot of the way we're delivering care. And I'll go through these very quickly, but we have to reorganize the way we deliver care to make it much more patient-focused, not specialty-focused or physician-focused. It has to be patient-focused. 2 is we have to measure the outcomes at that condition. And 3, measure and improve the costs, because that's the definition of value-based, getting better outcomes at lower cost. And the final part is to really incentivize all the players in the healthcare sector to align and stay aligned around this approach. Is we may have to change the way we pay the providers for treating patients. And so we're going to go, that's going to illustrate this with examples of all 4 of these. So as we get started, let's look at what do we mean by organizing around the patient's condition, organizing multidisciplinary teams. And I'm going to take 2 examples, and I'm not going to use our usual examples of surgical or cancer care. I'm going to use chronic care and population-based care to illustrate this principle. And the first one, and the medical condition we'll think about, is morbid obesity. And while I know that hunger and malnutrition is a major problem in low, medium income countries, it's also true that we tend to have obesity problems as well once people get access to food. And this is certainly a Western disease that's now a disease in China and India and the Middle East. And so the example, and one I came across a few years ago, is a clinic in the Netherlands, NOK, the abbreviation for the Dutch name up here. And they're the highest caregiver for morbid obesity now in Europe. And the reason they're the largest is because they're so good at it. But the way they organize care is very interesting. At the heart of it, permanent weight loss for people with morbid obesity does require surgery, a bariatric surgery. But it requires more than surgery. It does require multidisciplinary teams. And so at these clinics, they have a team of 3, a nutritionist, a dietitian, a physiologist for exercise, and a psychologist, because we really have to get people to think about themselves and their bodies differently as they go through this routine. And even before they have the surgery, you can see they have 6 1.5-hour sessions working with this team of the dietitian, physiologist, and psychologist to get them ready, get them on the right diet, start the weight loss, avoid substance abuse, start an exercise program. And then they have the surgery and the recovery, but then they follow up with them for monthly meetings for the next 12 months with the same multidisciplinary team, because the metabolism has changed. You're going to have to adjust the diet. The exercise routines may be different, and you have to stay with them psychologically so they stay the course. But the outcomes are just amazing. They have the highest sustainable weight loss of any weight loss treatment center in Europe. And one picture is worth 1,000 words. I hope you can see this picture. So this was a team of 11 individuals at the start of their training. And you can see they're a happy but rather obese group. And here's the same group in the same position 18 months later. This is success. This is what we want to accomplish. We've treated and we've cured this condition, and we've done it in a sustainable way through this multidisciplinary team working over a complete cycle of care. So why do we advocate for this? This is a good example. Is we want to concentrate volume. The more volume you do, the better you get at it. And so you want to have this be a center of excellence that people will come to from around the region. Because you may not have the volume in each Caribbean island to have one of these centers of excellence. But certainly you have the volume for one of these, almost for each major chronic condition. Somewhere, maybe different islands specialize in different things. Similarly in Africa, Asia, or South America. So we want volume. And that enables us to form this multidisciplinary team that can deliver the integrated care, but it's the psychological care and the nutritional care, and also understand the social determinants of health. People are coming from poverty. They may have food insecurity and housing insecurity. And we have to deal with those issues as well if we're going to get permanent, sustainable improvements. And they're not just doing an episode. You come in, a transaction. We want to have this team manage over this complete cycle of care from initial diagnosis all the way through to successful conclusion. Well, many healthcare conditions, including primary care, actually is never ending. So how do we think about this for population care? So I'm going to focus on a very successful set of clinics that has been established in the United States. It's not for everybody. It's targeted at older, poor adults. So in the U.S. health insurance plan, they're eligible for Medicare, for the health care plan for the elderly, but also for Medicaid, for people who can't afford even the premiums for normal health care insurance coverage. So they're focused on low-income older adults, and they locate their clinics in centers where there's a high concentration of low-income elderly people who typically are very ill. They have multiple fragmented visits with different physicians and specialists, and very high cost. This is the highest cost population segment we have in the healthcare system. And they open these clinics, which is very high touch and very friendly. And it includes not just the diagnosis and treatment centers, but also social centers. It's a community center. And so you come for your health care, but you also come for movie night, and you come for book clubs and bingo nights. And among the reasons why this is important is if one of your patients, just loves coming to the movie night, and 3 weeks in a row she's missed movie night, well, that something's going on in that patient's life. And they actually, contact the person, send a van out to find out, what's gone wrong? Why have you stopped coming to movie night? And this way you can often prevent much more serious downstream consequences. So at each one of these clinics, when we first started teaching this case, and David came to our program where we taught it, they had just 14 clinics outside of Chicago, one city. And now they're in 14 states with 80 of these clinics and growing 10, 20% every year. And so the first visit that a patient has, they're visited by a multidisciplinary team, which I'll show you on the next slide. But they do this initial assessment and the workup, get a sense where they are. They risk adjust them. Are they in critical condition or serious condition, or are they basically healthy? And based on their classification into one of these 4 categories, that determines how often they come back. And so when they come back for the second visit, the course of care is specified, the medication review has been done, and they work closely with the patients with the frequency of intervention, a function of the risk characteristics of the patient. And so at each of these clinics, what's the multidisciplinary team? Well, of course, we have the physician that's specialist in dealing with the elderly population. You need someone to manage the clinic. You have somebody who helps the patient with what we call the social determinants, help them with housing, with food, getting other kinds of coverage, because there's a lot of other things going on in their life. Of course, the people who organize the community events, the person who welcomes them when they come in so they feel welcome and calls them by their name. They have somebody who does the medical records and all the information so the doctor doesn't have to take the time. We have the nurse. And every patient has a care manager. And this is the one who works specifically with the patient, making sure they understand the treatment, reminding them about appointments, making sure they come in. So again, the doctor's not doing this, the nurse is not doing this. This is another person that interacts directly with the patient. So a great example, again, of a multidisciplinary team for that condition. And what are the results? These are the happiest patients in healthcare. They have a very high score of willingness to recommend, 90%, whereas the normal in U.S. healthcare primary care is 3%. So the patients love being treated in this type of a setting. They're also healthy, as measured by typical quality scores in healthcare, adjusted for that age population. And it's lower cost because they have 50% fewer hospitalization incidents. And so, yes, it costs you more to treat them in this more holistic, integrated way. But those visits, hundreds of dollars, are far cheaper than an emergency room visit or an inpatient stay, which in the U.S. is $40,000 or $50,000. So you spend more on prevention and working with the patients and understanding them, and then you spend much less on the very acute care. So these are just 2 examples of very, very successful centers of excellence of organizing multidisciplinary teams around the medical condition. Okay, second is the measure outcomes. And healthcare has a lot of measurements, but not all of them are outcomes. And we just published a paper, actually just last month in New England Journal, on this whole scene of measurement, the measurement scene in healthcare. And we start out measuring, do we have qualified people? Does the doctor have the right credentials? Has the nurse, graduated nursing school? Do we have safe facilities where people can come? So these are all important and they're necessary, but they're not sufficient. These are just the inputs to the healthcare process. And then the lean and the quality movement came to healthcare, and maybe you talked about this at the conference. So we have a lot of measures now on quality and safety and compliance. Are we doing the same thing each time the patient visits and getting the right drug at the right time, using evidence-based pathways? And again, this came out of the Japanese management movement, and it's a good thing to have come in healthcare. But again, it's about measuring processes, but not the outcomes of care. Now, the clinicians are starting to do much better at measuring what they call clinical outcomes. But their clinical outcomes are things that have gone wrong. These are the violations of the Hippocratic Oath of do no harm. So the clinicians are very good at, safety incidents and wrong side surgery and acquired affections when you came to the hospital or the clinic. And certainly we want to reduce these things, and we want to have fewer defects and fewer safety incidents. So it's good to measure these. But when the patients come to you, they don't come to you to avoid safety incidents or to avoid complications. They come to you because they want to be cured. You want to relieve their pain. They want to relieve the infection. So just measuring the defects doesn't tell whether you've actually cured and solved the patient's problems. So ultimately, we have to be able to measure outcomes as perceived and reported by patients. And as one of the clinicians in our paper writing group, our research group, said, only patients experience the pain and suffering and the relief, and only they can therefore report on it. And so there's an increased movement, and this has to go on even further, on patient-reported outcomes. Now, one of the things that does make measurement of outcomes could be misleading or hard is some of the outcomes depend on the patient's pre-treatment condition. I mean, Toyota can specify what kind of sheet metal and what kind of components they get, but healthcare providers, people show up with all kinds of sizes and ages and comorbidities and obesities and substance abuse, and you have to treat them. And the outcomes do depend on the patient's pre-treatment status. And so if we're going to interpret the outcomes, we should also interpret them in light of what they look like at the time they came to us. So this is kind of complicated. This won't happen, obviously, overnight or the next 6 months, but it's a journey we must go on because we need to be accountable to our patients and to our payers and to our communities for the outcomes ultimately that we do deliver. Why are outcomes so important? I mean, the accountability is one of them, but even the clinicians need to get this so they know when things have gone wrong and, and where they have an opportunity to improve. And especially if you can compare outcomes across clinics or across hospitals treating for the same condition, then there's an opportunity of feedback and learning of how to do it better. And we have remarkable examples of this. It gives you guidance if you're choosing between two different care pathways or two different treatments. Over time, you'd like to know which one works better than the other. And the only way to know that is to find out from the patient, which ones really did alleviate their condition and treat them. So it's going to help you, as even as scholars and as researchers, to help choose among alternative pathways. Outcomes are multidimensional. We want to be able to talk about with the patients what might they reasonably expect when I treat them. Not everything may be perfect. What are some of the risks? What are the kind of dimensions of things that might go wrong? And so the patient can participate in the decision making. We still have this external accountability, and as we'll see later, this now becomes the basis of contracting with our payers. And presumably the payer should pay us for solving the patient's problem, not just for doing things. And we can't really make the payment contingent on outcomes unless we have good, valid measure of the outcomes that we're producing. But this would be revolutionary in changing the way we finance and pay for healthcare. Okay, third is the work that I personally have contributed to this, which is on the costing. And as David mentioned, I have a developer of activity-based costing, and when we adapted this to the healthcare setting, we actually can make it work by looking at how the care is delivered in the clinics, in the hospitals, in the doctor's office. What are you doing to treat the patient with that condition? Who does each step? How much time is it taking? And what does that person cost? And what does the equipment cost? And add to it, the HIV drugs, the anti-malarial drugs, other vitamins and drugs that are done, and add that all up to get to the total cost of care. So when we apply activity-based costing, and this started in, obviously, in doing joint replacements in Boston-based hospitals, but I'm going to give examples of how we're now doing this in rural clinics in Haiti and in Africa. We just follow the patient. The patient comes in, they're seen, an office assistant checks them in and looks at their health records, gets them out. Physician assistant may do an initial triage on the patient. You may need to take various diagnostic tests. You have a lab technician or an X-ray. You have physicians that are beginning to, they'll have some interaction with the patient. And you have a nurse who's actually giving the instructions and helping the patient. So we develop these process maps of how we're treating patients. And then we have to find out, we have 6 different types of people that actually in a simple office visit. We have to find out what each one of them costs. So we look at their total compensation over the year, salary and fringe benefits. And we also look at how much capacity they provide. How many days a year do they show up to do this work? And how many minutes a day are they available to treat patients? And that'll give us our total minutes per year provided by each doctor, by each nurse, by each physician assistant. And therefore, we can calculate a cost per minute. What is the physician cost per minute? What is the nurse cost per minute? So I'll show you the numbers, typical numbers for Western healthcare workers. So a surgeon might be $6 a minute, a nurse $1.12 a minute, a scribe 50 or 60 cents a minute, clerical person 60 cents a minute. So you see this enormous dispersion of how much we pay people for doing various steps in healthcare. And this shows you if you have a doctor, especially such a scarce resource in a low, medium income country, doing work that an office assistant could do, that's a terrible misuse of resources to take, a scarce time of a doctor or a nurse when we could have a clinical assistant do the same work. And that's what's going to get revealed by this process. Because when we string together all the process maps for treating a whole condition, if you're doing tuberculosis visits, what's the initial visit? What does each subsequent visit look like? What's the final visit? And if we look across that whole 6-month cycle of care, how many minutes was spent by each healthcare professional? And we know the cost per minute. And so we can multiply and add it up to get, this was the total cost of treating this patient for that condition, tuberculosis, over the cycle of care, perhaps 6 months. And we never saw this data before. We never understood what it cost us to treat a patient for HIV. What does a pregnancy cost? What does a mastectomy cost? And now we have the opportunity of actually knowing that. And there's enormous variation. Going to our knee replacement example in the Western sector, we did a study of 30 high-volume hospitals doing a very standard procedure, knee replacements. And there was more than a 2-to-1 variation from the 90th percentile to the 10th percentile for doing the same condition on the same type of patients and getting the same outcome. I mean, it was just stunning. No one had believed that you could have more than 2-to-1 variation for treating that same condition. What caused the variation? Well, how much you paid for the device that you put in. There was enormous variation in what these places were paying. How much time did the surgeon take in doing the surgery? What was the pain management you were using? How quickly did they get to physical therapy after the operation? Were they discharged to home or to a skilled nursing facility? Plus all the other materials. So lots of things contribute to the higher cost. And once you see that, you have the opportunity in this setting of going and learning from the lowest cost provider. And no one was lowest cost across the whole cycle of care. But you could learn from who was ever lower cost at each step in the process. And you could see just going from the 90th to the 75th percentile lowered cost by 15%. And you keep going down. And so the opportunity of getting the same outcomes on the same patients, but doing it more efficiently, can be really quite dramatic. So what does this mean? I mean, how does this apply in a low and medium income setting where many of you are? So once we had mastered this technique on surgeries and acute care in Western hospitals, we actually did a project with Partners in Health, an organization I hope you're aware of, does amazing things in Latin America, Caribbean, and South America and Africa. And we went to 5 of their clinics in the central highlands of Haiti, not even in Port-au-Prince, but in the rural areas. And we looked at 5 different clinics, and we did this procedure. We actually had the people there keep track of how much time they spent at each step as they dealt with a patient. And so here are the 5 facilities, those are the names of the columns. And we looked at this for 8 or 9 high-volume conditions. Now, the patients didn't show up and said, I have TB or I have acute adult pain. But this was the classification that they made when they diagnosed the patient. Some of this you can see is women's health, pregnancy, family planning. And even within Haiti, and everyone's rough, you could see that there's more than a 2-to-1 variation for, this is a prenatal visit, between two of these facilities. So this huge variation in cost persists even when we go outside Western medicine to medicine practice in low and medium income countries. And then we can go in and find out, well, what causes the variation? And the blue line here is the personnel cost. So the higher cost one, you had the nurse spending more time talking with the patient and educating them on this antenatal visit. In Los Cabos, which is a much smaller rural clinic, they could only spend 9 minutes. Now, unlike the joint replacement, here the 9 minutes is a defect. That's not enough time. And so here the low cost is a symptom of a problem, not an opportunity for cost improvement. Why is it so short? Is they're understaffed. You have too few people here, and you have long lines of people who, walked for 6 hours to get to this clinic, and they're in pain and they're suffering, or they want to know how to, get through a pregnancy. And in order to process all these people, they have to have meetings that we've learned were just much too short. And often, here multivitamin was given in this visit 97% of the time in this clinic, which was better staffed, better resourced. But here only 20% of the time. Drug costs were lower. Why was it given only 20% of the time? Is because they didn't have enough drugs. They were stocked out. And so again, this was a defect that they discovered, is that they weren't giving the right, the drugs at the right time at the right place. So what we're learning as we apply the activity-based cost model in these low, medium income settings is cheaper is not better. Cheaper is a problem. We're not spending enough in these primary care clinics. And it's twofold. One, it's understaffed, and as we're learning in another study, we're actually underpaying our medical workers. They're getting paid too little. And how do we know this? Is based on the study that we did in Haiti. We're starting to do studies in Africa. And 2 of the graduate students at Harvard volunteered to do work under the funding of the Global Fund to go to Zimbabwe and study how was care delivered in Zimbabwe. And so here's one of our students, Catherine, and she's here in a clinic in Zimbabwe. And this is one of the slides that I showed you earlier in this talk. And so she's teaching them how to do time-driven activity-based costing in TB clinics in Zimbabwe. And they get a process map. Here's what happens in that initial first visit for a potential visit. And you can see they have a clerk, they have a nurse, they have a pharmacist, they have lab personnel. So just like in office visits in the US, you have different types of healthcare professionals, and they spend different amount of time, 3 minutes, 6 minutes is shown here. And so they mapped out the clinical pathways in 9 different clinics, rural and urban clinics in Zimbabwe. And the Global Fund said, we've been funding tuberculosis care in Africa, for 10 years. This is the first time we learn what's really happening on the ground, how care is given. And so we have all of our scientists in Geneva telling people how you should treat tuberculosis patients. What we learned is they weren't being treated the way we thought they were going to be treated. We find out what the pathways they were actually using. And we found out what the true cost was to deliver this care. And this is going to be built into the next funding plan in the National Strategic Plan. They saw opportunities for task downshifting, shifting work from nurses and doctors down to clinical assistants and physician assistants, get a much more efficient use of your healthcare personnel. They found the patients were coming back every 2 weeks, even if they had to take a 6-hour walk from their village to get there. Why do they come back every 2 weeks? They didn't trust them with the drugs, so they made them get only a 2-week prescription of drugs. Well, that's hard on the patients, and it's costly to the facility because they're seeing them every 2 weeks. And they say, well, why don't we just give them a monthly supply? And then they don't have to keep walking back twice a month. They can only come once a month, and it's lower cost to us, and we get the same outcomes. In fact, better because we get better compliance. And they learned that personnel costs were a much higher part of the cost. They used to think it was just the drug cost, but they learned personnel were more expensive. Not all the clinics had testing machines, and so the clinics without testing machines, they had to have a motorcycle courier take the specimen and drive it to the urban test facility. Then they had to wait and get the results back, bring the patient back 2 weeks later when they finally got the results. So I realized that this was very costly and not good for the patient. Maybe we should just put more of these diagnostic machines in all the clinics so we don't have to use motorcycle transport. So just lots and lots of interesting findings. And Global Fund is now saying, we're going to do this throughout, all the places where we work, because we really understand this. This is a management tool, not just a costing tool. And based on that, I've been talking with the people in the U.S., in PEPFAR, involved with HIV care in Africa, and we've started projects. Even last year, in the midst of COVID outbreaks, we were able to get staffing at these projects, and we've completed preliminary studies in Tanzania and Uganda on the cost of HIV care at these clinics. And the people in PEPFAR, they're keeping this stuff secret. It's stunning results. They're finding that when they were paying, the costs were the numbers are still sensitive, it's still being learned, but the costs were 85% less than they had been led to believe. They thought their cost per case, if we would say it was 100, and it's actually closer to 15. And where's all the other money going? Well, it's going to consultants, it's going to administrators, it's going somewhere in the bureaucracy, but where it's not going is it's not going down to the people delivering care, the nurses and the nurse assistants and the clinical assistants. And these people are paid so little that they can't even work in the clinics 5 days a week. They have to take other jobs to feed their children and clothe them and send them to school. Well, that's not good. And the doctors that get paid so little, eventually they leave and they'll go to Abu Dhabi or Saudi Arabia or England and become doctors there. That's a terrible thing to have happen. And so we have to take some more of this money and make sure the people are paid adequately and we have the staffing. And we can do this if we eliminate all the inefficiencies between the money that's sent in at the top and how much is lost until it gets to the bottom. So we're really excited about this opportunity of taking this type of care, into these countries. So David, I had some thoughts on payments, but I'm going to stop now because I think I haven't really covered a lot of this work. And so let me open it up for any comments or questions or, maybe we're finished here. But I hope you give you a picture of this multidisciplinary integrated care focused on the condition, measuring and learning from our outcomes, and measuring and improving on what our costs are to deliver that care.
So Bob, thanks for that very rich and informative discussion. And it's good to see greater emerging market participation in value-based healthcare. One of the big questions, and again, just to sort of cement the conversation, value-based healthcare as outcomes over cost, essentially. One of the big considerations or barriers is that many sort of providers' business models are based on a volume-oriented strategy whereby patients are expected to be treated in perpetuity and return, right? How do we get providers to see the value in value-based healthcare?
Well, David, there could be two parts of the story. One is in many health systems, including the U.S., when you're being treated for an acute condition, like cancer or, heart failure, where you have to do surgery, you're basically on a fee-for-service world. And even chronic care, you're paid per visit rather than for the treatment. And so we want a payment model that really covers all the costs for that condition. So in the two examples I showed you, say for that obesity care, there should be one payment for almost that 5-year treatment cycle, or at least the 18-month treatment cycle. And that payment pays for the 6 months of pre-treatment work, it pays for the surgery and the recovery, and it's going to pay for the 12 monthly visits post-surgery. And it's going to be contingent in some way on achieving sustainable weight loss, significant and sustainable weight loss. So rather than get paid for each step along the way, you're going to get paid for the whole treatment and for the outcomes. And in the case of the clinics for the elderly, they actually are paid an annual payment from the U.S. Medicare system, but the payment is risk adjusted to reflect the high cost nature of that poor elderly population. And so that clinic takes on all the risk for treating those patients. So they get a monthly payment, and that's all they get paid. And they have to absorb all their costs of treating them at the clinic, but also all hospitalization and all specialist costs. So it's in their best interest to keep the patient healthy and to lower the frequency with which they have to see specialists or hospitals. But should they go, they should go to hospitals and specialists with whom they have a relationship that's also going to deliver high quality, low cost care. So this idea of maybe a capitated payment, but that it covers the complete cost for that condition. Is that, can I answer that question?
Oh, no, absolutely, Bob. And to your point, just to sort of wrap up the discussion as well, in managing costs, one has to have a very clear understanding of what the costs are, which require data, which requires a relatively robust data infrastructure. Have you had any challenges with acquiring this data in emerging markets? And if so, how can emerging markets greater acquire the level of sophistication of the cost of their processes to be able to implement value-based healthcare?
Yeah, well, the reason, among the reasons I took the time and trouble to take you through time-driven activity-based costing is you get a sense of what data you need to collect. And so we do need these process times and the steps, and we do need the cost per minute of the various types of healthcare personnel. But we can put that on an Excel spreadsheet. We don't need a huge, big ERP system. And in healthcare, we found innovative ways of collecting the data. So in Haiti, they bought every healthcare person a little clock they could keep on their desk. And they sampled every 10 patients that went through a clinic. And so in the sampling, if they selected a patient, they put a pink piece of paper in the patient's medical record. And so when the patient showed up at a station and they saw it was a pink sheet, they said, look, I'm going to start the clock that's sitting on my desk. And they just recorded the data in real time of how long they spent with them. And then we had a data analyst at the end of the day key punch in all that data. But the data just goes up into a cloud. So you have a database that sits up in the cloud that's holding this data on process times and costs, and can do the calculations that I was showing you. And I think as long as we have some type of data technology at the clinic that people can key punch in and the opportunity to upload to some software in the cloud, that we actually can keep track of the data we need for doing the costing analysis. Fortunately, it's not that complicated.
Well, let's hope that the pandemic has really spurred us to reimagine what our healthcare business models look like, and moving forward into the new normal. I'm optimistic about the Caribbean and other emerging markets being able to benefit from the best practices that you and your team have found in implementing VBHC in emerging markets. So, thanks again, Bob, for sharing your time, for sharing your mind, and we appreciate you here. Handing back over to Terry.
Thank you so very much, Dr. Walcott. And, we just heard from a legend, just for our attendees who are there. I've grown seeing this name. This name has, in terms of Bob Kaplan, has always been associated with greatness and excellence and knowledge. And so just to be able to have this kind of exchange in an open source platform, again, making this kind of knowledge accessible is really what we're trying to do in terms of bridge the gap. So we just want to take the opportunity to thank each and every person who has been a part of day one, because this is a 2-day forum. But we thank all of our panelists. You can see they were top tier. These are high-leveled persons at the top of their field. They are the thought leaders within their industry. And the fact that they would make the time to be a part of this not only speaks to their brand, but it also speaks to the brand of Novamed as well as Catalyst. So therefore, what are the key takeaways? We saw some common themes going through, and of course, guys, you can jump in very quickly. Healthcare is a global priority. It is not just health, but it affects social as well as economic. So it's a big deal. Reimagination, going back to the term that Kirk used earlier, we have to reimagine how we view the topic of healthcare, how we treat it, how we deal with it, and how do we view our roles. What are the parts that we can play in the future, not just as consumers, but as the researchers, the developers, as well as the entrepreneurs? How do we fit ourselves within the ecosystem? We looked at education, the importance of education and equity and access, especially in marginalized communities. Whether it's the healthcare or not, the ecosystem, the stakeholders, if we're gonna plan and we're gonna strategize to put things into place, it has to be for the long term. Yeah, we won't be able to predict everything, we won't be able to predict crises, but we can prepare to do a little bit better. Change is hard, we understand that, but for entities that deliver healthcare, if you still do not use technology or innovation or some form of digital platform, you will be left behind and you will not be able to serve and deliver healthcare in the manner in which you need to. Innovation and technology makes no difference if everyone does not have access to it. We said it earlier. Healthcare is more than just wards and hospital beds and doctors and nurses. It's also community health workers, and there's the entrepreneurial side and the different offshoots that we need to also consider, which is a part of the ecosystem. And finally, we need to become patient-focused, patient-centric, and have them be a part of the knowledge exchange and the shared information. Collaboration, coordination, communication, cooperation were all themes for day one of the Catalyst Health Innovation Forum. Is there anything you guys would like to add before I give them the next housekeeping for tomorrow?
No, certainly. I just want to say, firstly, a major thank you to everyone who has participated, of course, but also a very big thank you to the team at the IDB across their various divisions that have supported this vision to deliver everything that you just mentioned. And I think, Mr. Kaplan or Bob Kaplan's, presentation captures a lot of what this is really about, right? He's not a medical practitioner. He's not a doctor. And I don't think, without discounting their obvious important role, I don't think you would see that level of insight being captured by anyone else, really, someone who gets to sit at that seat. And that is why we're saying, look, from whatever space you sit in, there's a role that you can play in this industry, and there's a value that you can bring to the table. We don't focus on bringing thought leaders, we focus on bringing doers, right? And absolutely, everybody who has presented today is active, doing something in this space, and really creating impact every single day.
And value, a lot of value they offer.
Yeah, no, and I'll double click on what both of you just said. I mean, the IBB has stood out as a collaborative institution, right? And I think it's demonstrative of what we're trying to drive in healthcare. Healthcare is by definition multidisciplinary, and while we in emerging markets, certainly in the Caribbean, we sort of view ourselves in a silo. The possibilities and opportunities within healthcare are way beyond our shores, and there's the famous adage. Alone you can go fast, but together you can go far.
That's mine.
It's important for us to be able to, rethink as we rebuild our healthcare structures, or economic and or social structures beyond this, within this pandemic and beyond. And again, a big thank you to everybody for participating and for really sharing in the vision.
I don't appreciate the fact that you're trying to take my job, because that was going to be my outro. That is really what I was going to say. It's one of my favorite African proverbs, which is, if you want to go fast, go alone. But if you want to go far, we go together. So you're coming to take my job. I realize that. I need to hide my papers. But thank you again to each and everybody, across the globe who registered, who participated, you asked questions, you took your notes. Thank you so very much. We do appreciate your company and your time. And we just would like to reiterate that tomorrow it's the same time, same place, same link. Again, #Catalyst 2021 if you want to catch up on anything that you might have missed today. And certainly go and follow the pages on Instagram at Catalyst HIF and on Twitter at Forum Catalyst. So again, same time, same place. We begin at 9 a.m. tomorrow. Of course, that's our time. And we look forward again to continuing some amazing discussions in this space. Again, I am Terry Curl Reid. It was a pleasure serving you as host. Again, I was joined by Dr. David Walcott and of course, Kirk Anthony Hamilton over there. And this was powered by Novamed. We'll see you tomorrow.